Hi everyone, I'm Dr. Aladdin Sagar, and this is This Week in Pulmonary and Critical Care Medicine. If you're like most of us working in critical care or pulmonary medicine, you barely have time to keep up with the flood of new studies that land every week. This podcast is meant to bridge that gap, a short, focused review of a few key articles that could change how we think or practice at the bedside. Every week, I'll try to pull together 2 or 3 original trials that have direct clinical relevance, and one review or editorial that gives us something to reflect on as clinicians and educators. My goal isn't to summarize everything. It's to highlight what truly matters in the ICU or on the ward, where decisions are made in real time and evidence has to translate into action. Before we start, a quick disclaimer. What follows is for educational purposes only. It doesn't replace clinical judgment or your institutional guidelines. Think of this as a conversation among colleagues meant to sharpen how we reason, not tell anyone what to do. This week, we'll cover 4 new papers. A New England Journal of Medicine trial that questions whether we really need arterial lines in every patient with shock. A JAMA study exploring personalized resuscitation based on capillary refill time, and why it may outperform our traditional lactate-driven approach. Another JAMA paper revisiting sodium bicarbonate in severe metabolic acidemia with AKI, a question that refuses to die. And finally, a New England review on how to teach trainees to navigate clinical uncertainty, something that affects every one of us who mentors young physicians. You'll find all the article links in the description below. Let's jump in. For decades, arterial lines have been synonymous with good ICU care. We place them almost automatically for any patient in shock, assuming that continuous blood pressure monitoring must improve outcomes. The EVERDAC trial, published a couple of days ago in the New England Journal of Medicine, dared to test that assumption. This French, multi-center, pragmatic, open-label, non-inferiority trial enrolled just over 1,000 patients with various forms of shock within 24 hours of ICU admission. They were randomized to either early arterial catheter insertion, the standard invasive strategy, or management with automated brachial cuff monitoring only, the non-invasive strategy. If a patient in the non-invasive group later met pre-specified safety criteria, for example, failed cuff readings, need for ECMO, or high-dose vasopressors, clinicians were allowed to insert an arterial line. The primary outcome was 28-day all-cause mortality, with a non-inferiority margin of 5 percentage points. The results surprised many. Mortality was 34.3% in the non-invasive group versus 36.9% in the invasive group. The adjusted risk difference was minus 3.2 percentage points with a p-value of 0.006 for non-inferiority. In other words, not inserting an arterial line early was just as safe as inserting one. Device-related complications told another story. Bleeding or hematoma occurred in 8.2% of patients with arterial lines versus only 1% without. That's an 8-fold increase in procedural complications. Now, to be clear, this doesn't mean we should abandon arterial lines altogether. They remain essential when vasoactive support is escalating, when blood gas sampling is frequent, or when non-invasive readings are unreliable. But this trial makes a strong argument against reflexively inserting one on arrival. In other words, if a patient on low-dose norepinephrine is stable and cuff readings are consistent, maybe that line can wait until the clinical trajectory becomes clearer. We've long equated technology with safety. This reminds us that sometimes less monitoring can still be good medicine. Next, we move to JAMA, with an interesting study related to personalized hemodynamic resuscitation. Fluid resuscitation in sepsis remains a moving target. For years, we've relied on lactate clearance and mean arterial pressure as our compass. Both imperfect, both prone to lag behind real perfusion. The Andromeda Shock 2 investigators asked whether a more physiologic, bedside-accessible target, capillary refill time, could do better. Across 86 ICUs in 19 countries, more than 1,400 patients with early septic shock were randomized within 4 hours of diagnosis to either a personalized capillary refill time-guided resuscitation algorithm or usual care following standard hemodynamic targets. The protocol was meticulous. Clinicians pressed the distal phalanx for 10 seconds, timed the color return, and aimed for 3 seconds or less. If capillary refill time was prolonged, they used a structured pathway assessing pulse pressure, diastolic pressure, and echo findings to tailor fluids, vasopressors, or inotropes. The primary hierarchical composite outcome, mortality, duration of vital support, hospital stay, favored the intervention, with a win ratio of 1.16. That translates into more wins driven largely by shorter duration of vital organ support, less time on vasopressors, ventilation, and renal replacement therapy. Mortality alone wasn't significantly different, but trended lower. In the accompanying editorial, the authors called capillary refill time the holy grail of sepsis assessment, a marker that's free, repeatable, and instantly interpretable. They pointed out that lactate reflects a complex mix of hypoperfusion, stress response, and metabolism, whereas capillary refill time measures what actually matters: skin perfusion and microcirculatory flow. From a bedside standpoint, I think this study legitimizes what many of us intuitively do when lactate looks low to clear, but the patient looks okay. If the skin is warm and refill is brisk, maybe we can ease off the fluids or down-titrate vasopressors rather than chasing a number. It's also a win for resource-limited ICUs. Capillary refill time doesn't require labs or technology, only vigilance and consistency. This question refuses to die. Should we treat severe metabolic acidemia with bicarbonate? The BICAR ICU-2 trial, published in JAMA a few days back, gives us the most definitive answer yet. Conducted across 43 French ICUs, this open-label RCT enrolled 640 patients with pH equal to or less than 7.2 and KDIGO stage 2 to 3 AKI. Half received IV 4.2% sodium bicarbonate to target pH equal to or more than 7.3. The rest received no bicarbonate. At 90 days, mortality was virtually identical, 62.1% versus 61.7%, with a p-value of 0.91, so no survival benefit. But there was a meaningful secondary signal. The need for renal replacement therapy fell from 50% to 35%. Time to dialysis was delayed by roughly 15 hours. Adverse events, hypernatremia, volume overload, were rare and similar between groups. In the accompanied editorial, the authors cautioned against overinterpreting this renal replacement therapy reduction. They note that clinicians knew the allocation and could have been less eager to start dialysis in patients receiving bicarbonate. The mortality neutrality, despite improved acid-base status, suggests the therapy's physiological appeal doesn't translate into better outcomes. For me, this reinforces a middle path. I'll use bicarbonate as a temporizing measure when pH is extremely low, for example less than 7.1, especially in hyperkalemia or when dialysis is delayed, but not as routine therapy. The broader message is that correcting numbers is not the same as correcting physiology. We love interventions that fix lab values, but this trial reminds us that patient-centered outcomes should trump biochemical perfection. Clinical uncertainty is something every physician experiences, but few of us are ever formally taught how to deal with it. In this New England Journal of Medicine review, Ilgen and Dhaliwal take on that gap, arguing that uncertainty isn't a flaw to eliminate, it's a core clinical condition that needs to be recognized, named, and managed. They start by pointing out how medical culture unintentionally discourages open acknowledgement of uncertainty. From the first day of training, we're rewarded for confidence and punished for hesitation. Our documentation systems demand precise diagnoses, even when we don't yet have one. Over time, This shapes a mindset where uncertainty equals incompetence, a dangerous distortion. They outline a conceptual framework for how clinicians experience and manage uncertainty. First, recognizing uncertainty. Clinicians notice uncertainty through cognitive, emotional, and behavioral cues. A nagging doubt, an uneasy feeling, a subtle sense that something doesn't fit. These gut moments are not weakness. They're early detection systems for cognitive dissonance. Second, classifying uncertainty. They propose distinguishing between two major types: epistemic uncertainty, which is when we lack knowledge or data, like not knowing if a lung opacity is infection or malignancy. This can be reduced with more information, better imaging, consultation, or time. The other type is aleatoric uncertainty, which is when outcomes are inherently unpredictable, such as whether a patient with ARDS will tolerate prone positioning. This can't be eliminated, only accepted and planned for. This distinction is key for both teaching and practice. When trainees know which kind of uncertainty they're facing, they can respond appropriately, seek data for the first, adjust expectations for the second. Third, responding to uncertainty. Experienced clinicians use cyclic processes of planning and monitoring. They form a hypothesis, act, reassess, and adapt. What differentiates experts isn't confidence. It's the ability to recognize when their confidence should drop. The review then dives into educational strategies for cultivating uncertainty tolerance. One is to normalize it early. Supervisors should verbalize their own uncertainty on rounds, saying, "I'm not sure yet, but here's how I'd think through it." That models reflective reasoning. You should also encourage uncertainty articulation. When a resident says, "I think it's pneumonia," a good follow-up question is, "How sure are you, and what else could it be?" Then you should teach metacognition. Help trainees recognize their cognitive biases: premature closure, anchoring, and overconfidence that often arise when uncertainty feels uncomfortable. And last, create psychologically safe environments. Fear of judgment makes trainees conceal doubt, which limits learning and increases error risk. The authors also note that new technologies, including AI, may reduce epistemic uncertainty by improving diagnostic accuracy, but they'll never eliminate the aleatoric kind. Predictive models can show probabilities, not certainties. Teachers should therefore reframe technology not as a solution to uncertainty, but as a tool for managing it more intelligently. This review resonated deeply with me because it captures something every attending recognizes: that how we handle uncertainty defines the safety culture of our unit. I found that when I openly say, "Let's think this through together," it not only teaches critical reasoning, but also reduces anxiety among trainees. The take-home message: uncertainty isn't the enemy of good medicine. It's a constant companion, and learning to manage it with humility, transparency, and structure is a professional skill, not a personality trait. That wraps up this week's review. Let's take a step back. Across these 4 papers, there's a subtle but consistent theme: rethinking reflexes. The EVERDAC trial reminds us that sometimes our monitoring habits are more about tradition than evidence. Andromeda Shock 2 shows that personalization, not protocol rigidity, may shorten suffering and resource use. BICAR ICU 2 teaches that not every biochemical abnormality needs immediate correction. Physiology matters more than pH. And the New England Review reminds us that uncertainty isn't a sign of weakness. It's a sign of awareness. Medicine moves fast. It's easy to get lost in metrics, scores, and devices. but these studies bring us back to fundamentals. Look at your patient, think critically, and question dogma, including your own. If you found this episode useful, share it with colleagues, fellows, or residents. It's meant to spark dialogue. You'll find all article links in the show notes. I'm Dr. Aladdin Sagar, and this has been This Week in Pulmonary and Critical Care Medicine. Take care, everyone.